Welcome to WealthCare INC, your go-to for quick videos on key healthcare topics. Today we will cover comprehensive kidney care contracting, or CKCC, which is one of the biggest Medicare shifts in kidney care. It changes the traditional approach of what gets measured, what gets rewarded, and how dollars flow for patients with advanced chronic kidney disease and end-stage renal disease. If you lead kidney operations, healthcare finance, or value-based performance, keep watching. I'll explain what CKCC is and what leaders need to know. CKCC is part of the Center for Medicare and Medicaid Innovation's Kidney Care Choices model. It's built for traditional Medicare beneficiaries with advanced CKD and ESRD. The model rewards coordinated care that improves outcomes while lowering avoidable total cost of care, especially hospitalizations and high-cost complications. Participation happens through a kidney contracting entity, or KCE. This is the organization that signs the model agreement, receives the payments, and is accountable for performance for the aligned kidney population. The goal is simple: delay progression when possible, engineer better starts, reduce avoidable utilization, and support transplant pathways, while improving outcomes and lowering total cost of care. CKCC targets patients with CKD stages 4-5 and those with ESRD. Success isn't about more visits, it's about fewer admissions, better transitions, and a seamless end-to-end patient experience. CKCC is offered through 3 contracting tracks: graduated, professional, and global. Think of them as increasing levels of financial risk and reward, tied to total cost and quality outcomes for an aligned kidney population. The original Kidney Care First model, designed exclusively for nephrology practices, ended in 2025. In 2026, CMS extended comprehensive kidney care contracting until December 31, 2027, which must include nephrologists and transplant providers and may include dialysis facilities. This model shifts towards long-term sustainability by adjusting the economics. CKD quarterly capitation payments drop 50%. The $15,000 transplant bonus ends for 2026 and beyond, and a 1% benchmark discount raises the bar for shared savings. Overall, CKCC's evolution reflects CMS's continued commitment to value-based outcomes in kidney care. Success in comprehensive kidney care contracting comes down to 3 things. First, governance and accountability, clear ownership of performance across care operations. Second, utilization management and clinical quality. Because ED visits, readmissions, and post-acute spend are the highest cost engine. Third, value-based outcomes. You need discipline around risk adjustment documentation, clinical profiling, interventions, and proving results. Now let's dive deeper. CKCC is an ACO-like model, so governance has to be centralized. You need clear organizational owners, standardized metrics, and an operating cadence that ties finance, administration, and clinical teams to the same scorecard. And because alignment is claims-based, you need tight population control. Track who's attributed, how the roster shifts, and segment performance across CKD versus ESRD. If governance and analytics are loose, performance becomes risky. The second lever is utilization management paired with clinical quality. CKCC performance is heavily driven by wasteful events like ED visits, readmissions, and poor medication or post-acute use. So best practice programs run a regular rhythm around those drivers, focusing on transitions of care outreach, rapid follow-up, med reconciliation, and high-risk care management. Clinically, you build optimal starts, access readiness, and modality education to help patients understand their options and prepare for transplantation or home dialysis, aiming for a planned transition rather than an emergency. Watch our other videos to learn more about renal care. Third is value-based outcomes powered by clean clinical data. CKCC isn't about chasing codes. It's about using accurate CKD staging and comorbidity profiles to target the right interventions at the right time. For example, if you can reliably identify CKD stage 4 patients at high risk for admission, you can prioritize care management, tighten follow-up, and prevent avoidable hospitalizations. Kidney care is changing, moving from volume to outcomes. And in CKCC, winning isn't about working harder. It's about working smarter, tight documentation, clean data, and proactive population management. The good news? It's absolutely doable. Build the strategy, manage avoidable utilization, slow progression, and align quality with analytics. This is WealthCare INC, the business of healthcare. Subscribe for clear, practical breakdowns of the models shaping care and what it takes to win.